Most people believe that if a surgeon recommends an operation, it must be the right choice. The doctor knows best. The hospital has the equipment. The paperwork is already waiting, clipped neatly to a board. Just sign here. I used to believe that too, until I started counting. Not charts, not procedures. People. Counting the patients who walked into the hospital under their own power and walked out permanently changed. Not always better, changed. A man who came in with back pain and left unable to walk at all. A woman who survived open heart surgery but lost 6 months of her life to complications nobody warned her about. Pause. And that's when something started to bother me. Deeply. Because here's what nobody tells you. The older your body is, the harder it fights just to survive an operation. Not the disease, the operation itself. My name is Dr. Daniel Carter. I'm a cardiothoracic surgeon with over 2 decades in the operating room. And today, I'm going to tell you the truth, not the brochure version, the real version, about 5 surgeries that carry serious, often hidden risks for people over 60. Let me ask you something. If you take a brand new car and a car with 200,000 miles on it, and you put them through the same stress test, do you expect the same result? Of course not. Pause. And yet, for decades, medicine treated a 70-year-old body the same way it treated a 40-year-old one. Same protocols, same expectations, same recovery timelines. That's starting to change, but not fast enough. Here's what actually happens inside an older body under general anesthesia. The heart works harder. The lungs take longer to clear the drugs. The kidneys slow down how they process medication. And the brain. Pause. This is the one that surprises people. The brain can become disoriented in ways that last weeks, sometimes months. There's a name for it. Post-operative cognitive dysfunction. And according to NIH-supported research, it occurs significantly more often in patients over 70 than most people realize. Now let me be clear about something. Age alone is not the problem. I've operated on 80-year-olds who recovered faster than some 50-year-olds. Age is just a number. But frailty? Frailty is not. Frailty means the body's reserve has dropped below a critical threshold. And studies show roughly 40% of people over 75 show signs of frailty. That number rises to nearly 60% over 85. So the real question isn't, can you survive the surgery? It's, can your body survive the recovery? Pause. Those are not the same thing. Let's talk about the first surgery. Open heart surgery in frail patients. Coronary artery bypass grafting, CABG. One of the most common major surgeries in older adults. On paper, it's straightforward. Blocked arteries, reroute the blood flow. And for the right patient, it works beautifully. But here's what the brochure doesn't show you. To perform this surgery, we stop your heart completely. We connect you to a bypass machine that takes over the work of your heart and lungs. For a healthy 60-year-old, that's manageable. For a 78-year-old with kidney disease, diabetes, and mild cognitive decline, that machine becomes a full-body stress event, all at once. Studies show that in frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications. Stroke, kidney failure, prolonged confusion, extended time on a ventilator. And here's the number that stops people cold. Up to 15% of high-risk elderly patients do not survive the first 30 days. Pause. Now ask yourself, were you ever told that number? But here's the part that gives me hope. Today, there are alternatives. Procedures like TAVR, transcatheter aortic valve replacement. No open chest. No stopping the heart. Far less trauma on a body that doesn't need a battle. It needs support. So no, this doesn't mean refuse surgery. It means ask one simple question. Am I a candidate for a less invasive option? That question alone can change everything. Let's interrupt this for a second. If you've ever been told, surgery is your only option, I want you to remember this moment, because very often, it's not. Surgery number 2, aggressive spinal surgery. Back pain in your 60s and 70s, almost universal. And more often, the solution being offered is surgical. Spinal fusions, multi-level decompressions, metal hardware fixed along the spine. Now listen carefully. Some spinal surgeries are absolutely necessary. If there's spinal cord compression causing paralysis or loss of bladder control, that's an emergency. No question. But elective spinal fusion for chronic back pain in older adults? The data is troubling. A major study published in the journal Spine found complication rates exceeding 40% in patients over 65 undergoing complex fusion. 40%. And these aren't minor issues. Blood clots, infections, hardware failure, and something called adjacent segment disease, where the spine above and below the fusion starts to break down because it's forced to absorb unnatural stress. Pause. But here's what frustrates me the most: the pain relief. In many cases, it's no better long-term than physical therapy and targeted injections. No better, but with far greater risk. A colleague once told me something I've never forgotten. Kevin, sometimes the best surgery is the one you don't do. Let me pause again. Have you ever been told surgery was your only option for back pain? Think about that. Surgery number 3, major cancer resections. This one is emotional, because when people hear the word cancer, everything inside them says, cut it out, immediately. And I understand that. I truly do. But surgery is not just about removing disease. It's about what comes after. Life. Pause. Let me tell you about Dorothy. Dorothy was 79. Sharp, independent, still drove herself to church every Sunday. She was diagnosed with pancreatic cancer. Her family wanted action, fast. The surgeon recommended a Whipple procedure, one of the most complex surgeries we perform. 6 to 10 hours. Removal of part of the pancreas, intestine, bile duct. Technically successful. The tumor was removed, but Dorothy never made it home. She developed complications within days. Infection, organ strain. Her body simply couldn't recover. She passed away 3 weeks later, not from cancer, from the surgery. Pause. This has a name, futile surgery. And according to data from the American College of Surgeons, nearly 1 in 5 elderly patients undergoing major cancer surgery experience failure to rescue, meaning a complication occurs and the body cannot recover. Now here's the question that almost nobody asks, but everyone should. If we don't operate, what are the alternatives for someone my age? Radiation, targeted therapy, watchful waiting. Sometimes, those options lead to more good days. And that matters. Surgery number 4, elective joint replacement in severely ill patients. Hip and knee replacements, incredible procedures, life-changing for the right person. But elective means something important. It means you have time. Time to think. Time to prepare. Time to improve your condition before surgery. Because studies show that in patients over 75 with multiple chronic conditions, complication risks rise significantly. Blood clots, deep vein thrombosis, pulmonary embolism, pneumonia, hospital-acquired infections. And here's where Harold's story matters. Harold was 76, a retired teacher, loved walking every morning, but his knee pain became unbearable. He scheduled a knee replacement quickly, no preparation, no prehabilitation. The surgery itself went well, but recovery didn't. He developed a blood clot, then pneumonia from limited movement. What should have been a 3-month recovery turned into nearly a year of struggle. Pause. Now compare that to another patient, same age, similar condition. But we delayed surgery for 12 weeks, focused on strength training, nutrition, optimizing blood pressure and glucose. That patient walked within days. Recovery was smooth, same surgery, different preparation, completely different outcome. So ask this, is my body ready for this surgery right now? Because timing matters more than most people realize. Surgery number 5, emergency abdominal surgery. This one is different. You don't choose it, it chooses you. A ruptured appendix, a perforated bowel, internal bleeding, no warning, no planning. And in patients over 75, mortality rates can reach 30 to 50% in severe cases, not because surgeons lack skill, but because the body is overwhelmed. Heart, lungs, kidneys, all under stress at once. And something called systemic inflammatory response syndrome can take over, leading to organ failure. Pause. So what can you do? 2 things. Don't ignore symptoms, and have the conversation now, not in a hospital hallway at midnight. Now. What matters to you? What quality of life is acceptable? These conversations are acts of love. Now let's shift, because information without action creates fear, and that's not the goal. Before any surgery, ask 4 questions. Number 1. What happens if I don't do this right now? If nothing urgent changes in 6 to 12 months, you have time, and time is power. Number 2. Is there a less invasive option? Medicine has changed dramatically. Options exist today that didn't exist 10 years ago. Number 3. What does recovery look like for someone like me? Not the average patient. You. And number 4. This is the one almost nobody asks. What is your complication rate for patients over 70? A good surgeon knows. And will tell you. Now let me tell you about Harold, not the knee patient. Another Harold, age 72, former construction worker, strong, but quietly afraid of losing independence. 3 surgeons told him he needed open heart surgery. 3 opinions, same answer. But Harold hesitated, not because he feared death, because he feared losing himself. His brother had surgery years earlier, and never came back the same mentally. So we talked, not for 10 minutes, for nearly an hour. We reviewed everything, his frailty score, kidney function, lifestyle, and we found another path. Aggressive medical therapy, cardiac rehab, no surgery. That was 5 years ago. Last year, he sent me a photo, standing in his backyard, holding his granddaughter, smiling. Pause. That's what this is about. Here's the most important thing I will say today. A surgical recommendation is not a verdict. It's the beginning of a conversation. You are not passive in this process. You are the decision maker. The surgeon holds the scalpel, but you hold the choice. Let's bring it together. 5 surgeries with hidden risks after 60. Open heart surgery in frail patients, aggressive spinal fusion with limited long-term benefit, major cancer resections where survival isn't the only goal, elective joint replacements where timing is everything, emergency abdominal surgery where preparation happens before the emergency. This is not about avoiding surgery. Surgery saves lives. Every day. I've seen it. I've done it. I believe in it. But the message is simple. Be informed. Ask questions. Get second opinions. Take your time when you can, because your age is not your weakness. Lack of information is. So let me ask you, what is the one question you would want answered before a major surgery? Think about it. Write it down, because that question might protect your future. And one final thing. Everything I've shared today is based on published research, including NIH-supported data and clinical experience. But your situation is unique. Always speak directly with your physician. Have the full conversation, unrushed, honest, because that conversation is where the best decisions are made. Take care of yourself, stay curious, and never stop advocating for your own health.